that? Set my computer on mute. So yes.
Yeah, that was the best example. Yeah, it's purely coincidental. So it turns out that they were probably at the cardiovascular. So
Should we get started? Okay, everyone. We're going to go ahead and get started. Thanks for joining us for Cardiology Grand Rounds, both in person and over Zoom. For those of you who don't know me, my name's Yaw Adjei-Poku, not to be confused with the elder Adjei-Poku. What I'm going to talk about today is COVID. Obviously, it's a diagnosis that everyone's been thinking about for the last 18 months or so. I'm going to start with a case from our hospital, talk a little bit about the background of COVID, sort of compare it to SARS pandemic that was present about 20 years ago or so. I'll go through the immunology and pathogenesis of the disease, the epidemiology, the cardiac manifestations. We'll talk a little bit specifically about acute coronary syndrome, arrhythmias, myocarditis. I'll end with another sample case, and then we'll have some time for questions. But by all means, if you do have questions throughout the case, please be sure to interrupt me. So this case is a 49-year-old female, is actually a patient of mine who had a past medical history of atrial fibrillation and was diagnosed back in 2016. She'd done fairly well without a lot of symptoms. She had hypertension, type 2 diabetes, which unfortunately was poorly controlled. She had a A1C of about 13% prior to for this presentation. Her outpatient medications were Lasix, insulin, metoprolol. She had been on flecainide and Xarelto. I had seen her because she was having periods of intermittent symptoms, palpitations. We had obtained an outpatient event monitor, which showed rare episodes or isolated episodes of what was likely an atrial tachycardia. No atrial fibrillation that was noted, at least on this monitor. So again, because of her frequent episodes of tachycardia and the absence of improvement with flecainide, the plan was for an outpatient EP study with an ablation, likely to target both her atrial tachycardia and atrial fibrillation if it was induced. Unfortunately, prior to the planned intervention, she had presented to her primary care provider with symptoms of fever, sore throat, congestion. She was having shortness of breath, cough, and headaches. I think with this constellation of symptoms, I think there's one diagnosis at the forefront of everyone's mind. So she was sent to urgent care for evaluation. She had a rapid COVID test, which was positive. Ultimately, she was discharged with a plan for supportive care, and then presented again about 1 week later with continued symptoms, fever, nausea, cough, and congestion. She was discharged again with plan for outpatient follow-up, but presented again to the emergency department. She was having worsening shortness of breath, continued cough, and congestion. This was her presenting chest x-ray, which showed multifocal areas of consolidation, most consistent with multifocal COVID pneumonia. It was done at the initial presentation. The thought for discharge, however, was her symptoms were mild and she wasn't hypoxic on presentation, so the plan was just supportive care, and she presented again with worsening symptoms. These were her laboratory findings. So I've highlighted a few of the markedly abnormal ones that we see in her case, and I'll talk a little bit about some of these later on. Her white count was elevated, her D-dimer was elevated, her LDH was elevated, her kidney function was previously in the 1.1 range, so that was elevated at CRP, BNP, so significant elevation of a lot of her laboratory values. Inpatient echo showed her EF was normal. She had no wall motion abnormalities. This was her presenting EKG, so atrial fibrillation, and she had periods of this also in atrial tachycardia. So she had incessant tachycardia upon presentation, which was refractory to medical therapy, both beta blockade and some antiarrhythmic medications. I think the on-call cardiologist actually had to go to Women's for the first time to further manage her presentation. She was placed on intermittent dialysis during the hospitalization. Her shortness of breath improved over the course of her admission, and ultimately she was discharged with 3 liters of nasal cannula. Unfortunately, the story does not end there. So about a month after her diagnosis, she was found down by her family and pulseless. CPR was administered by EMS, and they achieved a return of circulation. She was intubated in the field, but when she was in the hospital, she was unresponsive with no respiratory effort, and she had a poor neurologic prognosis. So ultimately, the family decided on comfort care measures. So obviously, the question that comes up is what happened? So we'll step away from that case to talk. No, she did not have an autopsy. So the structure of coronavirus, so it's an enveloped, non-segmented single strand positive RNA virus. It's the same subgenus as SARS. So I'm not sure if a lot of people remember. So SARS was another coronavirus that we were dealing with. It was first identified in November of 2002. The outbreak range from 2002 to 2004, caused a severe acute respiratory syndrome coronavirus. There were 8,000 infections and 774 deaths. So one thing that you can see is nowhere near as virulent as coronavirus is today. So there's a spike protein located on coronavirus which binds to the ACE2 receptor, which is present on the surface of lung alveolar and enterocyte cells. Binding of the receptor leads to virus and cell fusion, and that's thought to be the mechanism of viral entry into humans. So, I'll highlight a few differences between SARS and COVID. So the binding affinity to ACE2 appears to be stronger with COVID, and this difference may highlight the difference as far as infectivity between the two syndromes. ACE2 is present on type 2 alveolar epithelial cells, and that's what causes viral entry, leading to pulmonary complications. ACE2 on parasites and endothelial cells result in microvascular dysfunction and DIC. So what you can see is, entry of the COVID virus into these different cells manifests in different ways. So there's different stages of the disease, which is reflected by differences in clinical manifestations. So stage 1 is typically an asymptomatic phase. The virus binds to nasal epithelial cells, infection of ciliated cells in the airways. There's limited immune response, but highly infectious. And this is sort of the period that you can detect it via nasal swab. Oftentimes it's about 80% of cases are primarily in this first stage. Progression to stage 2 occurs with invasion and infection of the upper respiratory tract. And this is where manifestations of fever, malaise, and dry cough is present. And it's present in about 15% of the cases. Stage 3 is oftentimes the most severe case where the virus invades type 2 alveolar cells. There's a large inflammatory response of interleukins, TNF, and I think the cytokine storm results in inflammation and lung injury. This occurs in 5% of cases. One of the questions that often comes up is how come there's a difference between adult and pediatric populations as far as clinical manifestation of the disease. So children typically have a higher risk of admission for RSV and influenza, yet younger patients have milder symptoms if they do have COVID. The disease severity related to viral loads, what you can see is ACE2 suppression is oftentimes different between the adult and pediatric populations, as well as mild compared to severe disease. And there's also competition with other viruses. ACE2 is more abundantly expressed in well-differentiated ciliated epithelial cells. Human lung and epithelial cells continue to develop after birth. So younger patients have lower ACE2 suppression. There's a study looking at ACE2 suppression expression in mice, and as you can see over time, the expression of ACE2 is higher compared to early on. Adults also have a more robust pro-inflammatory response and more severe symptoms from COVID. Severe COVID characterized by massive inflammatory response is often thought to be the cause of severe manifestations. There's age-associated pro-inflammatory cytokines that also owe to the virulence of the disease. As far as competition, typically in children, there's simultaneous presence of other viruses in mucosa and lungs, and COVID has competition with these viruses, which limits its growth often. So one thing that we do know is COVID is extremely prevalent in patients with cardiovascular disease. There's concomitant cardiovascular conditions are present in between 8 to 25% of patients with COVID. On some data shows that 17% of patients with COVID have hypertension, 16% have cardiac disease, 10% have cerebrovascular disease. The data from the Chinese Center for Disease Control reviewed about 7,200 patients, and factors associated with adverse outcomes were hypertension, diabetes, and cardiovascular disease. These are all conditions that we take care of and deal with daily. The medical conditions of patients who died, 40% had hypertension, 22% had cardiovascular disease, 20% had diabetes. As far as COVID in patients with and without hypertension, there was a retrospective cohort that looked at 126 patients with hypertension and matched age and sex matched patients without hypertension. 21% of the patients with hypertension had severe COVID infection. The death rate was significantly higher in patients who had hypertension compared to those who didn't have hypertension. And what we see is hypertensive patients typically presented with higher concentration of some of these inflammatory markers, such as high sensitivity CRP, procalcitonin, and IL-6. Now, this sort of highlights that sometimes patients with hypertension and these other cardiovascular disease have underlying baseline sort of inflammatory states, which is worse if they have COVID. There was a study that looked at about 1,500 patients with COVID. There was an increased risk of ICU admission if COVID was present, if cardiovascular disease, diabetes, and hypertension were present in these patients. There were a higher percentage of deaths occur in patients with cardiovascular disease. A study of about 45,000 patients showed that a history of cardiovascular disease was associated with a 5-fold increase in case fatality rate. As far as ICU admission and mortality, there was another study that looked at just a little under 9,000 patients from 169 hospitals. These patients were admitted between December of 2019 and March of 2020. 25% of patients admitted to the ICU died compared to 4% of patients who were not admitted to the ICU. And risk factors for death were age, diabetes, cardiac arrhythmias, coronary artery disease, and heart failure. So I'll go back to this stage 3 of patients with coronavirus because it's often the patients in this stage who are the sickest of the sick. Now we'll talk a little bit about the mechanism. So the thought is that patients with severe COVID, part of the pathophysiology of their disease is an extreme cytokine release storm. And unfortunately, there's no sort of signal definition accepted, but what we do know is there's a blurred line between a normal response to COVID and a dysregulated response to the virus. What we know is cytokines are often helpful in controlling the infection, but oftentimes can also be harmful to the host. There are particular mediators of cytokine storm. These encompass disorders of immune regulation, which are manifested by constitutional symptoms, systemic inflammation, multi-organ failure. This is a list of some of the known cytokines that are present both in patients that have COVID and other patients that have viral syndromes. As far as the clinical manifestation and progression, oftentimes the onset and duration may vary. And what we see in patients is there are some patients that presumably are doing well for some time and then abruptly take a turn for the worse. Or sometimes patients present with pretty acute manifestation. And oftentimes the manifestations depend on underlying causes and some of the treatments that patients have received. But oftentimes the rapid progression is characterized by dyspnea, hypertension, vasodilatory shock, ARDS, DIC, and oftentimes death. As far as laboratory findings, often it's nonspecific. If you remember, the first patient that we had that I presented, she had elevation of CRP and some other inflammatory markers. Oftentimes nonspecific markers of inflammation are what are seen in patients with COVID. Patients frequently have abnormal blood counts, either leukocytosis, leukopenia, anemia, thrombocytopenia. These are all oftentimes findings of patients that have acute COVID. Typically, the cytokine storm with COVID is associated with poor outcomes, as we've seen previously with SARS. Typically, higher IL-6 levels are associated with poor outcomes. There's an hyperinflammation and tissue damage associated with poor outcomes in COVID, again, manifested by elevated CRP and D-dimer levels, hypoalbuminemia, renal dysfunction, sometimes pleural effusions are oftentimes seen. Again, going back to our patient, these manifestations are the manifestations that we saw on her, that she had an elevated CRP, her kidney function was abnormal. What we do know is that the immune response is oftentimes associated with the viral load. There's a correlation between nasopharyngeal viral load and cytokine levels, typically tumor necrosis factor, interferon alpha and gamma. What we do also know is that declining viral load is often seen with moderate cases, but not severe cases. The host immune response can be variable. And we see that when you look at patients that have asymptomatic COVID compared to patients that have pretty severe manifestations of COVID. This represents a conundrum as far as cytokines, that we do know that cytokines are important as far as treating and attacking a virus, but the dysregulation of cytokines is oftentimes the underlying mechanism of patients that have severe COVID. So blocking cytokine signaling may impair the clearance of COVID, which may increase the risk of secondary infections or lead to worse outcomes. So it's treatment of this cytokine release syndrome, cytokine storm, that has been looked at as far as possible treatment options for patients with COVID. So I'll talk a little bit about some of these treatment options now. One of them was the use of steroids. So this study enrolled hospitalized patients with COVID. Entry into the trial was thought to be approved if the attending physician at that time thought that the patient would not have adverse reactions to actually being on steroids. There was a 2-to-1 randomization of standard care versus the addition of oral or intravenous dexamethasone. Treatment with dexamethasone was 6 milligrams given once daily for a total of 10 days. There were about 11,000 patients initially recruited, with 2,000 that were in the treatment arm compared to 4,000 in the sort of typical or standard of care arm. So the recovery trial showed that there was a lower mortality at 28 days in patients that received dexamethasone compared to patients who didn't receive dexamethasone. There was a shorter duration of hospitalization in patients that received dexamethasone. And it was thought that there's reduced progression to requiring mechanical ventilation in patients receiving dexamethasone compared to those who didn't. Other treatment options include convalescent plasma. So the thought behind convalescent plasma is passive antibody transfer has been used historically in patients with viruses. So in 1918, influenza patients had antibodies that were administered to them. Previous results as far as patients that were given convalescent plasma were thought to be inconclusive. So Mayo Clinic initiated the expanded access program for convalescent plasma, and New Mexico was actually one of the states that had a few patients enrolled. Eligible patients were thought to be 18 years or older, diagnosed with COVID, and either have severe COVID or thought to be at risk for having severe COVID. Some of these risk factors were what we've talked about, if they've had cardiovascular disease, diabetes. The infusion of plasma was blinded, both as far as the titer levels. And I think some of the prior data as far as why convalescent plasma was not thought to prove benefit has to do with the actual titer of patients that were given convalescent plasma. In some of the prior studies, there weren't actually specific levels of titers that were looked at. It was just you got convalescent plasma or did not. So I think the level of the titers actually corresponds with potential benefit. So there was a low risk of death in patients that received high titer levels. There was no difference in patients receiving ventilation before transfusion. So I think the thought is that if you reach the point where you're under mechanical ventilation, there's no real significant difference. There's reduced mortality in patients not receiving mechanical ventilation as far as antibody levels. Another treatment was Remdesivir. It's an adenosine analog. It was initially developed during the Ebola crisis as far as treatment for patients with Ebola. It binds to an active site of RNA polymerase, which is thought to terminate RNA replication. There's some in vitro studies that have showed inhibition of COVID. The ACT-1 trial looked specifically at Remdesivir and potential benefit as far as treatment in patients with COVID. So that enrollment was from February of 2020 to April of 2020. There were 60 sites enrolled. About 45 of those sites were in the United States. Eligible patients received either Remdesivir or placebo. Randomization was performed by site and also disease severity. Administration of Remdesivir is typically a 200 milligram loading dose with 100 milligrams per day from day 2 to 10. And patients that were receiving treatment, they were prohibited from receiving any other off-label treatments. So the thought was to look specifically at the benefits of Remdesivir for these patients. So it did show that there was shorter time to recovery between 10 to 15 days when looking at patients that received Remdesivir compared to placebo. As far as severe disease, that benefit held true. 11 days to recovery of patients that received Remdesivir compared to 18 days. So the benefits are reduction in disease burden and also prevent the progression to severe stage of the disease. There was another study, Baricitinib, which is an orally administered selective inhibitor of JAK1 and 2. Artificial algorithms have showed some benefit as far as the treatment of, predicted some benefit in patients that had COVID. So this was the ACT2 trial. Patients were enrolled from May of 2020 through July of 2020. There were 67 sites, 55 in the United States. And there was a 1-to-1 ratio of Remdesivir and Baricitinib compared to Remdesivir and placebo. So patients receiving the combo treatment had faster recovery times. There was also a mortality benefit in patients who were admitted requiring oxygen that received the combo treatment. And what's most important about this study is there was no significant difference in adverse reactions. Initially, there was some thought that there would be an increase in adverse reaction, but there was no significant increase between patients that received the combo and those that received Remdesivir alone. There were other studies that looked at combination with dexamethasone. I've highlighted the benefits of dexamethasone. So they did look at dexamethasone with both of these treatments. There was no significant difference as far as benefit. I'll talk a little bit about cardiovascular complications. This is something that oftentimes we see in patients that have COVID, manifested by either myocardial injury, myocardial infarction, myocarditis, and arrhythmia, which is often something that we see in electrophysiology. So the mechanism of myocardial injury is thought to be increased physiologic stress of patients that have COVID, hypoxia, direct myocardial injury, and decreased oxygen supply. Typically, this is manifested by high elevations in cardiac biomarkers. And what you see is patients that do have these significant elevations in cardiac biomarkers are more likely to be sick. So patients admitted to the ICU, 22% had elevations in their cardiac biomarkers compared to 2% of patients that didn't have, that weren't admitted to the ICU. It was more common that patients who died had significantly elevated cardiac biomarkers. So initial data from Wuhan showed, and this was very early in the stage of the disease. So what you see is there are not a lot of patients that they have looked at, but of 41 patients with COVID, there was an increase in high sensitive troponin I levels in 5 out of the 41 patients. And 4 out of 5 patients admitted to the ICU had elevations in their troponin levels. In a retrospective series of about 200 patients, a quarter of them had increase in troponin T levels, and patients that had elevations, whether they had associated cardiovascular disease or not, elevation in troponin was associated with higher mortality. Another retrospective study showed that 82 patients with myocardial injury, mortality was higher when adjusting for age and other comorbidities. 12% of patients admitted with COVID had elevated high sensitivity troponin I. And again, a large number of patients either admitted or admitted to the ICU show some myocardial injury manifested by abnormal troponin levels. There was another study that looked at a cohort of a little over 400 patients. 20% had abnormal troponin T greater than 99% of the reference limit. Mortality was associated with elevations in troponin T levels, where about half of patients with myocardial injury ended up dying compared to about 5% of patients without myocardial injury. So, I think all of these studies show an association between patients that have myocardial injury, troponin elevation, and ultimately mortality. As far as myocardial infarction, oftentimes we see patients with COVID that present with acute coronary syndromes. Again, the underlying mechanism of this is a profound systemic inflammatory response. And specifically, about 20% of patients with COVID have abnormal coagulation. A cohort study from China showed about 200 patients with COVID, half of them in cases had coagulopathy versus 7% of patients who survived. And this coagulopathy causes increased risk of plaque rupture and thrombus formation, and MI is a cause of death in about 40% of SARS cases. And I think that holds true to patients that have COVID also. Myocardial injury with DIC results in thrombosis of coronary arteries, severe cardiac dysfunction, and again is present in 71% of non-survivors compared to 0.6% of survivors. VTE is also something that we see in patients that have COVID. Infection with COVID predisposes patients to prothrombotic state. There's sort of three mechanisms, either direct through the way of microvasculitis due to viral damage, indirect, either hypoxia, downregulation of ACE2 inhibitor receptors, DIC, or behavioral, just that these patients oftentimes are sick or in the hospital for long periods of time. They have bed restriction or decreased ambulation on an outpatient basis with social distancing regulations. So a natural question that comes up when you think about these patients is, what is the role of anticoagulation, either prophylactic or treatment anticoagulation? Again, some initial data looked at empiric aspirin use. There were 400 patients included in this study, and there was an associated reduction in risk of ventilation, ICU admission, and in-hospital mortality with no significant increase in major bleeding. Another study, 20% use of empiric anticoagulation in patients who previously did not have an indication of for anticoagulation showed some benefit. Those types of anticoagulation were mostly low molecular weight heparin, and 30% of patients were on novel anticoagulant. So the initial data has spurred some larger studies looking at patients that have COVID and the use of anticoagulation in these patients. There's a study from Montefiore. The inclusion criteria included patients that had COVID that were tested positive for COVID within 24 hours of admission. And what they saw was elevated D-dimers were associated with increased mortality. And the use of Eliquis stratified by the level of patient's D-dimer was associated with improved mortality. Bronxcare study looked at 4 different groups of patients and anticoagulation. One group was anticoagulation prior to admission, so oftentimes patients that met indication and criteria for anticoagulation. The second group included therapeutic anticoagulation during admission, either that or prophylactic anticoagulation. And the fourth group was no anticoagulation that was given either pre or during the hospitalization. So what it showed was therapeutic anticoagulation had a lower mortality compared to prophylaxis in ventilated patients. There was an incidence of thromboembolism in these 921 patients. About 16 patients had VTE, 11 with ischemic stroke, 2 with limb ischemia. Elevated D-dimer levels were associated with higher mortality, increased rate of intubation, and thrombotic complications. Again, reflecting back to the patient that we had, her initial D-dimer level was in the 900s. There was a Mount Sinai study that looked at 2,700 patients. Mean hospital duration was 5 days. The median time to anticoagulation was 2 days. What it showed was ventilated patients, there was a 29% mortality of patients receiving anticoagulation. This is compared to a 62% mortality in patients not receiving anticoagulation. Again, the the benefit here is a reduction in mortality without an increase in significant bleeding. Arrhythmias in COVID is also very prevalent. Palpitations is oftentimes a common symptom of patients with COVID. Even now, we frequently see patients that have had COVID and are having more frequent episodes of palpitations or symptoms. Frequently, it's present in patients that are admitted to the hospital, and oftentimes one of the main reasons for admission to the ICU. There was a recent survey that Heart Rhythm Society performed. It was an online survey sent to EP professionals, both physicians and allied professionals, about 1,200 respondents, half of whom were outside of the US, and 76% of those had COVID patients admitted to their hospital. A lot of those surveyed described that they were taking care of patients that had both tachy and bradyarrhythmias, atrial fibrillation being the most common as far as tachyarrhythmias, with sinus bradycardia being the most common as far as bradyarrhythmias. I think here at NMHI, we've seen both patients, and the patient that I showed initially, she had worsening of her atrial tachyarrhythmia during their hospitalization, but we've seen patients with bradyarrhythmia. I think a few weeks back, we had a patient, a 38-year-old patient who presented with symptoms of pre-syncope and had intermittent AV block in the setting of COVID. We had put in a temp perm pacing system for about a week, and she had persistent episodes of intermittent block requiring pacing. And ultimately, she underwent implantation of a permanent device. What's interesting is on follow-up, she's not pacing frequently. But so, I think it highlights that oftentimes patients that have COVID can frequently present with some bradyarrhythmias, including heart block. Myocarditis is something that we all know as far as taking care of patients with other viral syndromes. It's the most common cause of myocarditis, either from direct cell injury or T lymphocyte-mediated cytotoxicity, and it's augmented by cytokine storm, specifically IL-6 is a central mediator of cytokine storm. It's been related to COVID and associated with ventricular dysfunction and diffuse myocardial edema. The thought as far as the proposed mechanism is threefold. One is an immune-mediated, either innate or acquired immune responses, an autoimmune related, or direct virus induced by creation of viral proteins that cause myocardial injury. Cardiac MRI has been a hallmark as far as diagnosing patients that have myocarditis. And I think during the pandemic era, we're seeing a lot of centers using cardiac MRI in patients that have COVID. This particular study looked at 100 patients with recent COVID infection. And what's interesting is these patients were otherwise asymptomatic, so likely would not have presented to the hospital in their post-COVID phase. These patients were compared to both 50 healthy controls and 57 risk factor matched controls. 78% of patients with recovered COVID had some abnormalities as far as their cardiac MRI, either manifested by late gadolinium enhancement, reduction in their ejection fraction, pericardial inflammation. And again, this was patients that were otherwise asymptomatic. So I think it highlights that there's probably some degree of underdiagnosis of patients that have myocarditis in the setting of sort of post-COVID. Some of the arrhythmias that we see at COVID, myocarditis, are both tachyarrhythmias, supraventricular tachyarrhythmias, bradyarrhythmias, or more profoundly ventricular tachyarrhythmias, which is oftentimes the mechanism of death for patients that have myocarditis. This was a case that was in the news last summer. It was a 21-year-old college basketball athlete who had contracted COVID in the summer of 2020, had then recovered and was continuing to play basketball. He collapsed suddenly during a game. He was rushed emergently to the hospital. He was intubated and sedated, ultimately recovered and was extubated. And cardiac MRI findings in his particular situation diagnosed myocarditis. 80% of patients with myocarditis have some arrhythmia, oftentimes reentrant arrhythmias, and again, specifically ventricular tachyarrhythmias. So, I think myocarditis is definitely one of those things that we need to be cognizant of and think about. And I suspect that's probably the mechanism of death in the patient that I presented initially. One thing that I do want to mention is oftentimes we have patients that have recovered from COVID that still continue to have a post-COVID syndrome manifested by profound fatigue, shortness of breath, inability to exercise or perform their activities of daily living. We have, through New Heart, we have a COVID recovery program, and the goal of that program is to restore or improve quality of life while reducing persistent symptoms after COVID diagnosis, improve breathing, gradual improvement in exercise tolerance and capacity. So I think this is something that we can offer to our patients who have been diagnosed with COVID and are struggling with symptoms during the post-COVID era. Thank you. What questions? Yeah. So I think it's early on as far as some of those recovery programs. I didn't see any specific data, but I think what we do know is that exercise tolerance and exercise is beneficial in patients that have underlying cardiac issues and pulmonary issues. So there's a lot of data as far as that's concerned. So I think oftentimes that data can be extrapolated for patients that are post-COVID also.
Patients with reinfection of COVID, is it due to differential phase 2 expression, or why are some patients prone to reinfection?
That's a good question. I'm not sure exactly. I don't know if it's, and the other thing that we do see is oftentimes reinfection of COVID, those cases are oftentimes severe or more severe than the initial infection, whether that's related to changes in the immune response with the first infection compared to the second one. I'm not exactly sure.
What about relation with obesity? I know that obese patients are more prone to diabetes and they have risk factors, hypertension, but is there anything independent of those risk factors? So anything particular about obesity that predisposes patients?
Yeah, I don't think I didn't see any data specifically on obesity. Like you mentioned, oftentimes those patients have other underlying medical conditions, either diabetes and hypertension. So I didn't see any data that factors specifically for obesity as far as BMI or something being an independent risk factor. But I would not be surprised if that is possible.
One of my favorite things to do is to have discussions with patients in clinic about the harms of the COVID vaccine. Just makes my day. And so, I have people that are asking me, about the harms And basically, my response, and bringing this up because I think you have a unit response to these crazy people, is that, basically out of 200 million vaccines, the incidence of myocarditis is negligible. And the incidence of myocarditis with COVID is quite high. What is the actual data on vaccine-associated myocarditis?
Yeah, I didn't see any specific data on vaccine associated myocarditis. I think the issue there is, again, underdiagnosis of myocarditis. That study that I showed as far as CMR, those were patients that otherwise were asymptomatic. And routinely, I don't think we'd be getting cardiac MRIs or screening for myocarditis in patients that otherwise did not have symptoms. So I think the problem is that oftentimes patients, have manifestations or at least MRI, clinical manifestations of myocarditis without true symptoms.
So you told that hypertension, diabetes, cardiovascular disease, all those patients are at high risk of COVID. So this is one question which often patients ask, right? When I have cardiovascular disease, how high is my risk? So other studies which look at specific risk associated with diseases like coronary disease, heart failure, arrhythmias, what is the risk compared with all these?
Yeah, so, I think those studies have clustered cardiovascular disease as a whole. That includes arrhythmias, coronary artery disease, hypertension, diabetes, and what we see as all of those things are associated with COVID. The other thing too that we see in patients, and this has been highlighted in other studies, is that there's some fear that if they have underlying cardiac issues, that there's some fear of coming to the hospital because they think that they'll potentially get COVID and they'll be at higher risk compared to other patients. So, that's definitely something that has been seen in data that, presentation as far as patients presenting with acute coronary syndrome has reduced dramatically in patients during the COVID pandemic, specifically in sort of March to summer of last year, that patients are less likely to present with chest pain, more likely to, there's an increase in out-of-hospital arrests, and I think that's all centered around some fear that if they have underlying cardiac conditions that there are increased risks, so they don't want to come to the hospital. But I think the important point there is that, those are the patients that should present to the hospital if they do have clinical symptoms.
I think you may have a couple questions on here. Let me try them.
Thanks, Yaw. That was excellent.
Thank you. So, yeah, I think one of the questions was whether insurance covers COVID recovery program. I actually do not know. That's a question that I can find out, and then I can